Welcome everyone. My name is Melissa Lujan with the National Center on Substance Abuse and Child Welfare. We want to thank you for joining our 5th webinar of our post-conference web series. I'm going to take a few minutes to go over some logistics for the webinar. We'll be taking questions throughout the presentation through the chat box on your control panel. At the end of the presentation, we'll reserve about 15 minutes to do Q&A. At that time, we will enable the raise your hand function where you can participate in the live discussion. Then we will unmute your phone line and you'll be able to ask Erin and connect with her that way over the phone line. Also, we will be having polling questions throughout the presentation. This will allow you to vote on the questions and you'll be able to see other responses. To participate in the polling questions, select your answer when you see the dialog box appear. And we'll just wait a few seconds for a majority of the audience to respond, and then we'll display the results. Today's webinar is entitled Mental Health Disorders in School-Age Children with Erin Telford. Dr. Telford is a licensed clinical psychologist who has been with the Children's Research Triangle since 2004. She is currently the project coordinator and clinical director of Family and Child Treatment Services, FACT, a clinic in Belleville, Illinois, funded by a 5-year grant from the Administration for Children and Families. FACT provides assessment and therapy services to a wide range of children and adolescents impacted by prenatal and environmental substance exposure, trauma, and disrupted placement. So I would like to welcome Erin.
Thank you, Melissa. Before we get started, just to do a brief explanation of, I'm going to be doing the presentation, and then Ann and Lauren, who are, everybody can see their names on the slide. I just want to give a thanks to them. They're actually our research director and our research assistant, and they helped pull together some of the data that I'll show you guys from our clinic a little bit later in the presentation. So in addition to what Melissa told you about my background, I also work at Children's Research Triangle, and that's where I've been for the past 8 years. In that role, I've done individual group therapy in addition to the psychological evaluations on the kids, and that I've been doing well before we received a grant from ACF to start the clinic downstate. So a little bit of a background with this and the kids that we're going to talk about. So before we get started, just a brief polling question is to see how many people are providing direct clinical services to kids and kids of any ages. So hopefully this will work and everybody votes. With the silence, I feel like it should be singing Jeopardy music or something. Okay, so out of everyone that's here, most people don't provide direct clinical service, which for me is helpful to know, but it's also kind of a good thing for everyone to see. A lot of what we're going to talk about, or what I'm going to talk about in this presentation, isn't necessarily clinical. It is based a lot more on research and kind of getting to what kind of the overall policy implications and treatment implications are for kids in the child welfare system. So it should have enough implication for everyone. Just going through with based on registration, most people are clinical case management, then there's the mysterious other category, and then some judicial and some administrative. Okay, so what we're going to talk about today, just kind of a brief overview. I'm going to start with a case example and talk about a pretty typical case that we see at our clinic. And then the idea of this is really to look at the mental health issues in the kids in the child welfare system. For those of us who work with these kids, it's kind of a little bit of a, well, of course there's mental health issues in these kids based on our experiences, but when you actually look at the data and at the numbers, it presents a different picture, and a picture that I think we're not always expecting. And that becomes really important because we need to know really what the rates are of mental health issues in this population, why they're occurring, what's causing the mental health problems, in order for us to be able to do something about it and figure out how to best treat these kids, how to best help these kids, both individually and kind of at a greater policy level. So we'll start, after the case example, we're going to talk about what the real prevalence rates are in the population. So how many kids are we really talking about? And then kind of the way that I conceptualize what places kids at a higher chance of developing mental health issues is kind of a risk and resilience model. So we'll talk about what risk factors contribute to kids developing mental health issues and a little bit about resilience, what the overall outcomes are for the long-term implications for these kids, and then what their treatment needs are, and then policy implications. At the end, we'll have some time for questions, and again, if there are questions that come through, please feel free to type them in the chat box. So kind of starting with our case example, this is, based off of, it could be based off of many different kids we see as one particular child I saw, but it's a pretty typical presentation. Everything's been changed, age, there's nothing identifying that would mark who this kid was. So we're going to talk to you guys about Martin. He's a 7-year-old boy who came into the clinic with his adoptive parents. He had behavior problems that started around age 2. At that point, he would have tantrums to the point where he would throw things, he would yell when he didn't get his way, he called people names. He threatened others even at a really young age. His parents described him as having quote-unquote nasty talk when he would be interacting with people. At preschool, he was aggressive to the point that he was suspended and kicked out. He would throw things. He hurt his teacher. He broke one teacher's nose at a point. He hurt classmates. He was aggressive towards his siblings. One of his oldest brothers actually moved out of the home at one point because he just couldn't kind of manage being in the house with him. At the point that he presented to the clinic, he was still having tantrums multiple times a day. They were lasting 30 to 60 minutes at a time. He wasn't able to calm down on his own. His parents had to physically intervene to try to calm him down. He would make suicidal statements. He would engage in self-injury. He'd scratch himself, bang his head against the wall, bang his head against the floor. He would make homicidal threats. He would gesture with weapons, but he never actually used one. So he might take a butter knife and kind of, gesture at somebody, but he never actually hurt anyone with a weapon at the time that I saw him. At one point, he was treated with Strattera, and after that, though, he developed pretty intense anxiety and had some paranoid delusions. He thought that people were after him, was seeing monsters that were coming to get him, and so that medication was stopped. So based on that information, and I'll give you guys a little bit more in a minute, what would you think, the following question, what is this child's diagnosis? And hopefully, I think we should be wrapping up soon. Okay, so pretty even split then between ADHD and then or conduct disorder, oppositional defiance, someplace in that disruptive behavior disorders, and some type of trauma-related diagnosis. Okay, so keeping that in mind, I'll give you guys a little bit more information. Kenneth Martin's background was his biological mom was 34 years old when she had him. While she was pregnant, she received limited prenatal care. She used alcohol, tobacco, cocaine, and marijuana throughout the pregnancy. He was actually born full term, didn't have any complications in the delivery, but he had a positive drug screen at birth for cocaine. His mom has a history of anxiety and schizophrenia, and in addition to her substance use. His dad had a history of learning issues and substance abuse as well, and he had a sister that was diagnosed with ADHD. After Martin was born, he was actually discharged home to mom and got intact family services through DCFS. But shortly after going back home, mom started using drugs again and alcohol. And during that time, she would kind of leave him with anyone who would take him. He would, at different points, she definitely would forget who he was with. She'd show back up, pick him back up again, but then end up leaving him with someone else. He was exposed to domestic violence, community violence, inappropriate sexual situations, but it never was known if he was directly abused. At one point, mom actually kind of kidnapped him back from some caregivers who had had him for a longer period of time, and he was finally ultimately removed by DCFS due to mom's noncompliance with their service plan. His first placement lasted a week, and then he went on to a second placement that lasted for about 8 months. He then went back to mom for 6 months, but the living situation was the same. It was very unstable. Different people were taking care of him. So he was removed yet again and put into a third placement. This is the family that eventually adopted him and actually brought him to the evaluation. But before the adoption even went through, there was a lot of back and forth before parental rights were terminated. There was appeals. So it was really up in the air for him for where he was going to live, who he was going to go back to. So kind of getting that, a little bit of additional information, what, kind of another same polling question as before, what is his diagnosis, and did your opinion change of the diagnosis from the first time? I think we're going to try to do, yep, there we go. Okay, so for this one, there was a pretty big change. More people think that he has a trauma-related diagnosis compared to ADHD or any of the other difficulties. And I'm not sure if it's going to show up with what percentage change, but you can see there was a pretty big change in opinion. So when I saw him, did a complete psychological evaluation in addition to having a medical evaluation done with him. He ended up on cognitive testing, was in the borderline to mild range of mental retardation. He had lots of deficits across the board with things. He had executive functioning problems. He had difficulties kind of shifting between activities and pivoting his behavior. He had adaptive delays. He couldn't do a lot of daily living skills that you would kind of expect for a kid his age. And some were even more delayed than what you would expect for a kid who kind of has overall cognitive delays. Not really a surprise, but all the social emotional testing, parent report measures, teacher report measures, things like that showed multiple emotional and behavioral problems at home and at school. And some of the testing that was done with him was trying to get at reality testing, which that came back as having questions about how intact his reality testing was at times, although it wasn't kind of blatantly psychotic at the time that I tested him. So this is kind of the last piece. So given that last little piece of information of how he did in testing, again, kind of voting about where you think his diagnosis is. Okay. So, all right, so there was still the primary diagnosis that most people think is trauma-related with the cognitive and developmental delays, some ADHD, but it kind of stayed pretty consistent from the beginning. You know, the purpose of doing this isn't necessarily that there's a right or wrong with diagnosing these kids, but it's just to show how when we start getting different pieces of the kid's picture and different pieces of the puzzle, how diagnoses can change and how the opinion that we have of kids can change based on what we know about him. In Martin's case, he's definitely a complicated kid, but again, pretty typical for the kids that we see here. The diagnosis that I ended up giving him was a mood disorder, and that was based on multiple factors. You know, he has a strong family history of mental illnesses, of schizophrenia, possible mood disorder with the mom. It's hard to know with the records that were provided. And the extent of his rages is pretty typical of what we see with early onset mood disorders in kids. He also definitely had some trauma issues going on and some attachment issues that were playing into that. The results of the medical evaluation indicated that he actually had fetal alcohol syndrome. He had all of the facial features that we see in kids that have fetal alcohol, which that contributes to some of his emotional ability, which we'll talk about a little bit later, and some of his overall difficulties. And then, of course, he had the cognitive delays. So the idea of this is just that these are the kids that we're talking about. It's never typically just one thing. It's usually a multitude of issues going on with them, and it's different layers of things. And so when we start breaking this down, we're going to talk about things more individually, but it's always important to kind of keep in mind how complicated these kids are that we're working with and that we're dealing with. So let's start, before we can really kind of look at what the prevalence rates and what the mental health issues are in these kids in the child welfare system, we need to have a good understanding of what the overall prevalence rate nationwide, regardless of population, for kids for mental health issues. And so this information is based on a Surgeon General report, and overall what it's found that approximately 20% of the population has a mental health disorder that causes some type of mild functional impairment. And so that can be anything from a learning disability to some mild anxiety. The rates of what's considered a kind of a more severe emotional disturbance is closer to 9% in kids. And when we actually start to break it down, less than 5%, significantly less than 5% of kids, kind of this is looking at school age, kind of 9 to 17-year-olds, have substance abuse issues. Disruptive behavior, which includes things like ADHD, conduct disorder, oppositional defiant disorder, is right around 10, 11%. And mood disorders are right around 7%. Anxiety disorders are the highest, and that includes anything from separation anxiety to post-traumatic stress, and those were anywhere from 10 to 15% for the kids. So that's kind of looking at the national averages, and that's something to kind of always keep in mind at that base rate of overall 20% nationwide of kids. And when we start talking about the child welfare system, you'll see that the kids have much higher rates. What is hard to kind of pin down is that there's a lot of different information out there on what the rates of mental health problems are in this population. Some studies have shown that it's about 50% of kids in the child welfare system have some level of mental health impairment. There was a study that was done based on the National Survey of Child and Adolescent Well-Being, which was a huge study, and we'll talk about it a little bit more later, that about 50% of the kids from ages 2 to 14 exhibited some clinical level of mental health problems. But they were looking at actual mental health symptoms, not actual disorders or diagnoses. So that could be a somewhat overestimate. Other studies have shown anywhere from 35 to 90% of children in the foster care system have some type of medical, dental, behavioral, mental health, something need. But again, that's pretty wide, and that's looking at a couple of different things and not specifically just mental health. Another study showed that 80% of kids involved in child welfare have some type of emotional behavioral disorder or developmental delays that require some type of mental health treatment. So it's a pretty wide range, and that's what starts to get a little bit hard is when we start to pin down what the issues actually are. It's a pretty wide variety. But even with that minimum number of kind of 50%, if we wanted to go with that, that's a significant rate of kids within the child welfare system that have some type of mental health disorder. When we compare them to other populations, because one thing that could be said is, okay, so you're looking at these kids in the child welfare population, but there could be contributing variables that make it seem like the numbers are higher. So some studies have actually looked and compared kids in the foster care system to the overall Medicaid population, so that would provide some type of control for SES variables and things like that. And what they found is foster care kids tend to still have higher rates of mental health issues than kids in the overall Medicaid population. There's a study in California that looked at Medicaid users, and kids in foster care in California are 4% of the Medicaid eligible children, but they actually were using 41% of all the kind of mental health services that Medicaid was paying for. So it was a significantly higher utilization rate. In Washington, 25% of foster care kids were using Medicaid reimbursed mental health services. That was compared to only 3% of kids that received AFDC were in accessing mental health services. So again, significantly higher for the kids who are in foster care. And in Pennsylvania, they found that kids in foster care were 3 to 10 times more likely to have mental health problems compared to kids that were receiving ASDC again. So when we actually look at that population, so looking at foster care kids compared to kids who are getting aid for family with dependent children at ASDC, the foster care kids had significantly higher rates of mental health disorders. If you look, across the board, depression, anxiety, ADHD, conduct disorder, bipolar disorder, and oppositional defiant disorder were all significantly higher. They also found that kids in foster care were 7.5 times more likely to use inpatient psychiatric services compared to kids just receiving mental health services and that had ASDC. So controlling, even taking out the SES and controlling for other variables, age, sex, race, all of these things, the rates still stayed higher in the foster care kids. Looking at kids compared to foster care kids compared to kids getting SSI benefits, again, similar results. With the exception of ADHD, the kids who were in foster care had much higher rates of mental health disorders. Oppositional defiant disorder, conduct disorder, anxiety were all significantly higher in the foster care kids. The exception was ADHD, and the reason for that is typically that ADHD is a qualifying diagnosis to receive SSI benefits, so there was a higher rate of that within that population. So when we look at things and kind of, again, just trying to understand what the real rate is of diagnoses, what diagnoses kids have, we have to kind of start to look at individual studies because you can see there's just a very wide range that we see. There was actually a study done in Utah, and Utah is in a unique advantage in some ways for doing these types of studies because within 30 days of coming into foster care, all kids in Utah, or all kids in the Utah foster care system have to have some type of screening for medical, mental health, dental, all of those issues. So between 2001 and 2004, they looked at roughly 6,000 kids that came into foster care. And the reasons for removal were pretty common to what's seen everywhere. Most of the kids were removed for neglect, then followed by issues of delinquency, physical abuse, and sexual abuse was actually the lowest reason why kids were removed. What they found was that parental substance use was a contributing factor in 45% of the cases, which was really significant. Most of the kids had some type of significant health problem. For example, they found that over 35% of the kids had a body mass index of 85%, which is really substantially high and places them at risk for all sorts of medical issues and long-term complications related to obesity. But what they found related to mental health was pretty significant as well. Their population was skewed towards the younger end, and even in the kind of the little kids, the 3 to 5-year-olds, 37% of those kids met criteria for at least one mental health diagnosis. For the school-age kids, the 6 to 12-year-olds, 50% of the kids had at least one mental health diagnosis, and 12 and older, it was almost 70% had some type of diagnosis. Overall, they had significantly higher rates of things like oppositional defiant disorder and conduct disorder, higher rates of mood disorders, and higher rates of ADHD. And they were basing kind of the comparison rates off of, again, the CDC's national data. So when you were looking at these kids that were coming into foster care versus the national averages, they were having significantly more issues. Now, the National Survey of Child and Adolescent Wellbeing, which I kind of referenced earlier, is another really big study. Overall, they looked at over 5,000 kids. This particular study was looking at a little less than 3,000 of them. The kids were aged 2 to 14, all involved in child welfare, and this was across the country, so it wasn't just one state. It was looking at 97 counties across the United States. And they followed the kids for 3 years, so they weren't just looking at diagnoses, but then they were trying to see whether or not the kids improved over time. The demographics of the kids were pretty consistent with what you would expect nationwide. And at baseline, their population was a little bit different, though, because about 92% of the kids that were at home, so that means that they were receiving, at least in Illinois, what we call intact family services. Every state is different. And only about 4% were in traditional out-of-home foster care. So I think that's a little bit different than what the typical numbers are for kids in the child welfare system. And it's important to keep in mind because some studies have shown that kids that remain in home and are receiving child welfare services do poorer, in part just because of difficulty accessing services. So that could be a contributing variable to that. But what they found overall was that yes.
It's Melissa. We have a question from the audience. Is there a relationship between mental health issues and poor prenatal care?
Yes, and poor prenatal care as far as just going to the doctor and getting visits, that not necessarily, but the outcome of what risks are associated with poor prenatal care, yes, rough. It's a very vague relationship. The women who tend to get poor prenatal care are going to be the ones that have other risk factors. So they're going to be more at risk for health complications like high blood pressure, preterm labor, preterm birth, intrauterine growth retardation, all of these things, and all of those things have subsequent risk factors for developmental delays, not necessarily quote-unquote mental health, like depression, anxiety, that kind of stuff, but definitely with developmental delays with kids later on. And we'll talk a little bit more about that when we talk about risk factors. So going back to this study and kind of looking at what they showed, 62% of the kids had some type of emotional and behavioral problems, and most common were thought problems, meaning more like ADHD type things, in addition to just pure attention problems. They had higher rates of post-traumatic stress, higher rates of depression. Over time, what they showed over that 3-year period that they followed the kids, 18% of the kids actually got worse, but that's to be expected. Most studies have shown that when we're doing treatment with kids long-term, 25% will get worse, and that's kind of what you expect. So that's within kind of what we call a normal range. What they did see, which this was optimistic and good, was that they saw improvement in overall total problems, depression decreased, and post-traumatic stress decreased quite significantly from 13% of the kids having symptoms of PTSD to 5% in 3 years. Part of that is that PTSD symptoms are very situational, and they're kind of quote-unquote easily treated in the sense that they are a situational thing that the kids are dealing with. So at the time that we tend to measure trauma symptoms, if the kids are getting trauma therapy, those things will get better. But what it doesn't reflect is kind of the developmental nature of trauma and the developmental nature of trauma problems in kids, which we'll talk about a little bit later. And one time capturing, even over 3 years or kind of a 3-year period, is not going to capture kind of the true nature of trauma in kids. But the fact that they did show improvement is good.
Okay, Erin, we have 2 questions that came in. One was, were the foster care rates higher as the ASDC population are reluctant to assess services when concerns are present?
I'm sorry, you cut out on me on that one. Can you repeat that?
Were the foster care rates higher as the ASDC population are reluctant to assess services when concerns are present?
That I don't know, and they didn't look at that, so I'm not sure.
Okay. The second question was, were the children who improved placed with families, non-relatives, etc.?
In which study?
That question just came in, so.
The one that I was talking about that I know the placement, and kind of where I was saying that they had a higher rate of in-home placement, which I'm going to guess that that's where it was coming from. The kids, it was 92% were in-home placement, so with their biological families. 4% were in traditional foster care, and 2% were in some type of relative placement. So hopefully that answers what the question was. So kind of just thinking about, at this point, have a general understanding of what the rates are in the population, as much as what I think we can, because it's kind of a murky issue when you start looking at all of this. But so quick polling question is, of the kids that you work with, what percentage would you say have some type of mental health issue? Okay. So most people were in the 50 to 75% of the kids that they work with have some type of mental health issues. And just like anything else, I think it all depends on the setting that individuals are coming from. If you're coming from a clinical setting, you're going to have a higher rate compared to other people. But just to kind of keep in mind where your kids are compared to kind of those averages that we were just talking about. So are you seeing higher rates in your kids compared to what the typical rates are for foster care? And the whole idea of this is kind of just, okay, you know, not really any new information. We all know that the kids have issues, but why is it important? And why is it important is because clearly it's a problem that's in the child welfare system, and there's long-term implications for it. The kids that have a history of maltreatment, have a history of involvement in the child welfare system, have much higher rates of mental health problems that persist into adulthood compared to the general population. They're 4 to 5 times more likely to be psychiatrically hospitalized for suicidality. They have increased risk for being put in jail, for unemployment, for not completing school. The ACE study, which most people are probably familiar with, has shown that with these adverse childhood experiences, in which maltreatment is one, foster care can be part of that, all of these things place them at much higher risk for long-term health problems. So higher rates of heart disease, cancer, liver disease, other medical problems. Some studies have shown that up to 33% of kids who were in foster care don't ever receive their high school diploma, which then that presents all sorts of employment issues and ability to provide as they get older. And 62% of those kids just aren't able to maintain employment. So when we take the vast number of kids who are ever involved in the foster care system and you kind of apply some of those percentages, those are really high rates of kids that have long-term issues related not just to their mental health needs, but also just to their involvement in the child welfare system as well. So then the question is really, why is this happening? You know, why do kids have mental health problems? And again, that's kind of a no-brainer question, because you're probably all thinking, well, they've had bad things happen to them, otherwise they wouldn't have been removed, and that's absolutely true. But the reality is, too, we can look at kids that have almost identical histories, and their outcomes will be completely different. So then the question is, well, why one kid and not the other? Why does the first child end up doing fairly well and the second child doesn't? And that's where it kind of gets into this idea of risk and resiliency, which isn't a new idea, but risk factors definitely contribute to the onset of problems, to how severe kids' problems tend to be and how long they last. Just because there's one risk factor, so child abuse and even very severe abuse, possibly for a child, it doesn't necessarily mean that the child's going to have negative outcomes. What research has shown is that it's actually the exposure to multiple types of risk factors that creates the higher risk for the kids. So it's not just that they were abused, it's that they were abused in a home that maybe the parents were using substances, that there was domestic violence, and then they were put into foster care, and because their behavior was a problem, they had multiple foster care placements, and they were moved around a lot. So there is a child that has 4 different risk factors versus a child who might have also had an instance of abuse and was just removed and placed into one placement and didn't have the parent who was using substances or wasn't exposed to domestic violence. So the more risk factors the child has, the more and more issues that they have long term.
Erin, it's Melissa. We have 2 questions that came in.
Okay.
Did any of these studies ask if children were on psychotropic meds, and if so, to what extent those receiving meds fell within the group that got worse or got better? That was question 1.
Oh, with the previous study, as far as, no, they didn't look at that as far as determining which kids got worse or which kids got better. Some studies, some of the Medicaid studies did look at whether or not the kids were using prescription medication from the standpoint of like a cost-benefit analysis, And just showed that the kids who were in foster care had higher expenditures on psychotropic medications, but that they did not use that as a control variable.
Okay, thank you. The second question was, what kind of interventions can be provided to children who are exposed to the risk factors to prevent incarceration?
Oh, we will get to the point that we're going to talk about interventions, and so I'll hold off on answering that question until we get a little bit further in about what this implies for treatment. And it's not specifically just for incarceration, but it's what things can be done in general to intervene with these kids to reduce their risk factors across the board. Because there's not necessarily any one thing that it's this risk factor, do this intervention, it's going to reduce this one outcome. All of those outcomes are increased risk for these kids given what they've kind of been through. So, give me just 1 second to kind of regroup where I was at. So when we were talking about these different risk factors, so child abuse kind of is an easy one to understand. When a child is in a situation where they've been abused, they're much more likely to come from an environment where poverty is common. Parental mental health is a huge risk factor. It is definitely a risk factor for increased rates of abuse, but then it leaves the kids at a biological kind of vulnerability early on before anything else, particularly for things like schizophrenia, bipolar disorder, depression, for increased rates of mental health problems. Parental mental health issues has higher rates of substance abuse, and prenatal substance exposure has higher rates of negative developmental mental health outcomes, et cetera, for kids, but it also, for kids living in an environment where parents are actively substance using, it places them at risk for neglect, which then has risk factors for self-esteem, depression, anxiety, things like that. Being exposed to domestic violence or community violence definitely places the kids at increased risk for depression, PTSD. Multiple placements we're going to talk about in a minute, much more in detail. And then just individual factors that the child brings. There are things that we can't explain in a child that places them more at risk, and there's some that we can. And one of those is the child's cognitive ability. So we know that kids who are average to above average intelligence tend to do better, and that can be a protective factor, just the same way that a lower cognitively functioning kid that tends to be a risk factor. But there's things with that's not even, that we can't even say that that's universal. Sometimes what we see is that kids who are lower functioning cognitively, in some situations it can be a protective factor if they are at a point that they don't understand a lot of what's going on. They aren't going to be as likely sometimes to personalize or internalize and blame themselves for some of what happens, which that sometimes happens with some of the kids who are higher functioning cognitively. So the child's individual factors also play, it can be a risk or protective factor for them.
Erin, we have a question that they want to know, is neglect included under the umbrella of child abuse risk factor in your last slide?
Yeah.
Okay, thank you.
So what we have to remember is that, just as I would say, identical exposure to risk factors, even with similar backgrounds, does not mean the same outcome, and that there's no single outcome regardless of what the experience is. So an example of this is there was a 10-year-old girl that I saw a couple of years ago, and she had a pretty severe sexual abuse history when she was a young child. She was actually involved in child pornography. She had witnessed extreme violence in the living situation that she was in. By the time she was removed when she was 4, she was actually almost at the point of death because she had been so severely neglected. And she was removed, put in the hospital, and then ultimately put into foster care. And she's a kid that, you kind of look at, and when we saw her, before she walked in the door, I expected lots of social emotional problems, lots of behavioral issues, kind of some long-term problems related to this, and she really was doing quite well. She had some lingering anxiety issues, particularly around kind of anniversary reaction times, where around times that she was removed, and kind of tended every year to be a trigger for her. But overall, she was doing really well in school. She was well liked. She didn't have any behavioral issues and got along well within her family. So there are some times that we just can't explain why a kid does well, and that's that resilience piece. Similarly, you can have two kids that have the exact same backgrounds, but because they're two different children, they will come out entirely different ways. And those are some of the things that we can't explain. When we talk about the cumulative risk versus single risk, let's take an example of, again, a kid that I saw actually just in the last couple of months who came in when she was 14. She was part of a sibship of 3 girls, all of which had been physically and sexually abused. But she was one of the older ones, and she had a longer period of abuse than her youngest sibling, and had also faced more issues living with mom, homelessness, multiple caregivers, different things along the way, that when her youngest sister came into the picture, although she also had the abuse history, she was removed at a much younger age and faced fewer of those risk factors. And her outcome was much different, and her younger sister did much better than what she did. And the girl that I saw had multiple psychiatric hospitalizations and ultimately was put in residential treatment because of how severe her behavior was. So again, it can kind of show the difference between those cumulative risks, the ones that just add and add and add and add, versus 1 or 2 risk factors. But it's not universal. We can't predict. So we're going to talk about these areas of risk a little bit more in detail. So we'll get to some of the other questions about some of the prenatal issues, what we mean by trauma, and kind of specifically what role placement has in all of this. And there's no real order to this. This is just kind of how I've divided it up. We'll talk about prenatal first, we'll talk about trauma, and then we'll talk about placement. And I say there's not really an order, but there is in some ways. Kind of the way that I conceptualize it in my head when I am working with a lot of these kids and with these families is I kind of imagine it as a house or as a pyramid, like within this picture. And their prenatal history, whether it's the substance exposure, which is what I'm going to talk mostly about, or those biological factors that they come in with, the family history of mental health issues, family history of substance abuse, that kind of forms the foundation for what happens to these kids. And there's a real big difference. It would be interesting if we can ever do a study to quantify it, but there's definitely a qualitative difference in the kids that we see that come in our door that have a history of prenatal substance exposure and trauma compared to the kids who come in who just have trauma histories. Our kids who have both do far worse than the kids who just have the trauma exposure. And in part, when we start talking about some of the difficulties that the prenatally exposed kids have, they're in a position cognitively where and emotionally where they can't deal with the trauma and the things that happen to them as well as a child who's had those same type of abuse and trauma histories, but that are cognitively more intact and have more resources to manage them. So that's why kind of the prenatal piece is the base, the trauma, which then happens to them, is the next level. And then the placement history is kind of what happens to them after all of this has happened and what role then that has. So kind of imagine it one leading to another, kind of. So prenatal substance exposure, when we think of it, most of the time, I think a lot of people think that we're talking about cocaine, heroin, kind of the quote-unquote big drugs or real illicit substances. And actually what research has repeatedly shown is that out of all the substances of use, alcohol actually has the greatest neurobehavioral impact. So it has the biggest impact on kids' cognitive, behavioral, social, emotional development. This, of course, is complicated by polysubstance use, and a lot of people, when they do use, aren't just using one substance. So we'll kind of walk through each of the major ones for a second just to understand their implications. So cocaine and methamphetamine are actually very similar drugs in the way that they work within the body. Methamphetamine works in a more efficient way, which is why on neurotransmitters, which is why it actually lasts longer, and the high is longer, more intense, and more desirable, I guess, for some users. Cocaine is much shorter. What we know from cocaine is that the studies have shown in kids who are in a good, stable home, so the parents aren't continuing to use substances, or they've been adopted and they're in a stable placement that way, there are no real cognitive differences between the kids who've been prenatally exposed to cocaine and the kids who have not. There's a few points difference in IQ scores, but not significant. What we do see is that the kids tend to have expressive language deficits. They also have increased rates of ADHD compared to other kids. And there's medical complications that are associated in general with the use of any stimulant, whether that's cocaine, methamphetamine, ecstasy, anything like that. And those can include preterm labor, the intrauterine growth retardation, so the baby doesn't grow as big as what would be expected for how long the pregnancy lasts. Placental abruption, which can result in lack of oxygen for the baby and, in worst case, premature death of the infant. The kids have a much higher rates of prematurity. They're low birth weight. The moms have hypertension a lot more because they are using stimulants, which then again is associated with a lot of these medical complications, low oxygen levels, and they have higher rates of stroke in utero. And some of the brain studies will actually show pictures of, where you can see the bleeds in the baby's brain. Methamphetamine, because it's also a stimulant, has those same medical complication risks. And what the long-term stuff with meth is still coming out. There was actually just a recent study that came out in pediatrics the last couple months that has shown more externalizing problems in the kids and higher rates of ADHD as the kids approach school age compared to when the kids were younger. In general, some of the studies have shown just general dysregulation as far as the behavior of the kids go. They tend to be kids that are harder to soothe, more irritable when they're little. Which we also see in the cocaine kids. And there's been some early evidence of academic deficits and some cognitive deficits, but that stuff has been really premature. It's still early to kind of say. And a lot of the studies that have shown those type of results have also been complicated by the fact that they weren't studying kids that were just exposed to methamphetamine. Most of the biological mothers were also using other substances like alcohol and cocaine and different things that we know have other outcomes, so it's kind of hard to say fully what the outcomes are going to be. So the study that just came out in the last couple months is the first one that kind of controlled for all of those extra variables and showed that there were some issues with their kids' behavior when they turned around 5. Alcohol is kind of a different story. Numerous studies over the years have shown repeatedly lots of different impacts on multiple areas of the brain. And in part, it depends on multiple factors. It depends when the mom drank during the pregnancy. It depends on the mom's ability to metabolize alcohol, the child's ability to metabolize alcohol in utero, all of these different kind of factors. But universally, what we see is that multiple parts of the brain are impacted, including the corpus callosum, which is that part of the brain that connects the right and the left hemisphere. So it's the exchange of information that's been related to higher rates of ADHD. The basal ganglia, which helps with the motor coordination issues. The parietal lobe, which helps control sensory processing. Limbic system, which is emotional control. And then the frontal lobes is one of the largest areas impacted, and they're responsible for executive functioning, language, and different things like that. Executive functioning is a really key part of our cognitive abilities. That's our ability to plan, to think through possible consequences of action, to organize our behavior, to inhibit our behavior, to make transitions throughout the day, not just physical transitions, but mental transitions, so being able to go from one task to another. All of those things are executive functions, and all of those things are impacted by alcohol because it impacts the frontal lobes. So what we see then in kids who've been alcohol exposed is that they have widely varying abilities. Universally, kids who have fetal alcohol syndrome tend to have much lower IQs, and fetal alcohol syndrome is the leading known cause of mental retardation. So in kids who have FAS, they have much higher rates of cognitive impairment. What we see and what I see clinically is not so much the kids who have that severe cognitive impairments, but I see kids who have a wide variety of abilities. So I might have kids who are overall kind of low average, but they have some things that they really, really do poorly in, and some things they do well in. So it's this kind of hit or miss function of their cognitive skills, which makes it sometimes more difficult to work with them. as far as at school and with parents, because some skills are really good and some things aren't good for them. We see kids with lots of academic and learning issues, particularly with kind of higher order thinking things. They tend to do well in rote tasks, rote math tasks, things like that, even sight reading, but they don't understand what they read. They struggle with story problems. They struggle with math as it becomes more abstract. So learning is definitely an issue. Lots of sensory processing issues, and these kids tend to be very dysregulated when it comes to their emotional and behavioral control. They go 0 to 10 very easily, poor frustration tolerance, and just don't handle kind of changes in routines, changes in pattern, changes in anything that they expect very well. We also see that the size of their brain is impacted, which for a diagnosis of actual fetal alcohol syndrome is one of kind of the characteristic things that we look for, is that they have microcephaly. But in general, these kids tend to have smaller brains. So that's one piece of the prenatal piece. The other piece that's not on the slide, again, is the biological history and the genetic history. So the kids coming in with a history of a mom who has bipolar disorder, or a dad who has schizophrenia or substance use, all of these different things that also can be a huge contributing factor. So then the next piece of the puzzle, if we are kind of dividing it up and looking at the prenatal pieces, is one piece of the puzzle, and then we look at the trauma piece. Trauma has all sorts of different outcomes, and we can use the different little squares on here, rectangles. We could change the order around any way we want. There's no specific order. But what ends up happening is when a child has a history of trauma, whether it's physical abuse, sexual abuse, neglect, they are at an increased risk for more and more difficulties. So they've been victimized. Depending on the child's age, that puts them at increased risk for substance abuse, suicide related to depression, self-esteem issues. Kids who have a history of sexual abuse tend to have or can have higher rates of promiscuity and sexual behaviors. They have relationship issues related to attachment problems. They don't know how to relate to other people, not just caregivers, but also peers. They struggle at school. They have mental health issues. And all of these things just kind of keep interplaying with each other and just put the kids at a higher and higher rate to be victimized again and again and again, not necessarily by other caregivers in their life, although that definitely happens, but they also are victimized by peers. These kids tend to be taken advantage of. They tend to be the kids that other kids will be able to pick up on and pick on. They're bullied, they're teased. So, and that just kind of starts the cycle again. So it kind of becomes this downward spiral of just ongoing risk factors, one after another after another. When I talked a little bit earlier about how there was the one study that showed that there was significant improvement in trauma symptoms, which was a great outcome and good to see, and probably in big part related to how much more we are recognizing the importance of treating trauma. But it also is concerning from the standpoint that trauma and the way that a child reacts to trauma changes over time. There's kind of a developmental trajectory to it. There's only so much that a child can deal with related to their trauma, usually at any one developmental stage. So if you have a child who was abused at a young age and they go through therapy, and maybe at the time that they're little, they're presenting with lots of behavioral acting out, dysregulation, things like that. They go through therapy, they kind of manage things and process things to the point that they can understand, and then they're doing well for a while. Their placement's stable, everything's going good at home, and then something might happen a few years later that kind of sets something off, whether it's that they remember something, whether it's an anniversary reaction to something, or just some random event happens. You might start to see more things reemerge related to their trauma history. At that age, maybe the child goes back into therapy again, they reprocess stuff, and they can understand things at a different level than at 9 or 10 than what they could at 5. You'll keep seeing this kind of pattern happen over time. And that's why a lot of times when we're working with families and working with kids, we do tell people that this isn't a one-shot deal. You don't just treat the trauma symptoms one time and then you're done. It's, you treat them and then you be prepared for the fact that things will come up again as the kids get older and that you might have to readdress them. So when we talk about trauma, neglect definitely is part of that, and neglect is often you're neglected. Early research, when we started looking at abuse and neglect, which is actually a really young field of research, they didn't even consider neglect as a type of trauma. It's even newer in the research field of really being considered. There's subtypes of neglect. There's physical neglect, emotional, medical, mental health, educational, and regretfully, most of those aren't even kind of addressed by the child welfare system. It tends to be very much focused on the physical or medical neglect for kids. I can only speak for my state's child welfare system, but it's rare that if you do a call that's really based on emotional neglect, that you're going to get a child removed or a child interventions that really kind of happen within the home, just because that's not the main thing that I think a lot of people recognize as neglect. But it's really important, and it's important because the kids that are emotionally neglected are the ones that start to see the world as, nothing that they put in it really is going to, they're not going to get back. So a lot of these kids are the ones that become really withdrawn and don't even really try to elicit reactions. They don't try to interact with others, and they kind of pull away. The overall outcomes with neglect, increased rates of death, of course, in situations of physical neglect. The kids have learning issues if they've not been attending school, or if they have been attending school, if what they've been getting at home doesn't actually meet the kids' needs or isn't helping them learn. Higher rates of low self-esteem, delinquency, aggression, poorer peer interaction, less peer interaction. These kids tend to have more developmental delays overall and more attachment issues, and particularly they tend to be anxiously attached to people. Physical abuse is easier to see. It's easier to recognize. If you see a kid who's been hit and has a bruise, it's easy to see that that is abuse, which is not as clear with the kids who've been neglected that come into your office or come into school or come anywhere, and they just don't necessarily look like something's happened. These are the kids that have the greatest risk of death based on the type of abuse it is. They have lots of cognitive and academic delays. They are more likely to engage in aggressive behavior, in part because that's what's always been modeled for them. Aggression was normal. Aggression was what was part of their everyday routine. So to them, that's normal and accepted, and that's how they'll respond. Higher rates of suicide. Their attachments tend to be very disorganized. It varies from anxious to avoidant, just kind of depending on the situation and based on what they had to do to kind of get by and survive. They have fewer positive peer relationships and clues of behavioral disorder diagnosis, anxiety issues, and up to 35–36% end up meeting criteria for a post-traumatic stress disorder. Sexual abuse. See if I can get the slide to go forward. There we go. Sexual abuse, again, is a lot more visible than what the neglect is. The kids who've been sexually abused have higher rates of depression and anxiety, lower self-esteem. Let me go back. There we go. Higher rates of post-traumatic stress disorder. These kids tend to run away more increased rates of substance abuse, increased rates of sexual behavior, and they tend to be less socially confident than their peers. So when we're pairing things, so when I said earlier that the kids that we see that come in that have both the prenatal substance exposure history and the trauma history tend to do worse, you can kind of start to see why. If you have a child who comes in who has difficulties in general just because of the way their brain was wired when they were born, essentially, at handling frustrating situations, of handling any emotionally charged situations, of understanding the consequences to things and understanding what's happened to them, and then they're traumatized in some way, they have a lot harder a time managing it and dealing with it and managing their emotional reaction than a child who has had the same type of trauma but cognitively is completely intact and doesn't have those prenatal vulnerabilities. Doesn't mean that one... Melissa?
Oh, Erin?
Yeah.
What percentage of neglected kids meet the criteria for PTSD?
Off the top of my head, I don't know, but it tends to be a lower rate. The higher rates tend to be with physical abuse and sexual abuse. So the kind of third piece to our puzzle is the placement history, and this is the one that I think is not looked at nearly as much as what some other things are. The trauma history is easy for us to see. And most of the time, I think that we remove the child from the situation, we protect them, they're no longer being abused, they're no longer exposed to environments in which there's domestic violence or there's multiple placements, and as far as like people in and out of the home or homelessness, and all their needs are being met. So we kind of think that we've done what we needed to do, and that stabilizes the kids. But what actually is being found in more recent research is that that isn't true. In one study that was done in 2005, they actually found that the average number of out-of-home placements once a child was removed from care was almost 5. So, overall, this was a small study. They were only looking at 120 kids, but the kids that they saw had an average of 5 different placements. And what they found that the increased number of placements resulted in a direct increase in the number of total behaviors that the kids had, and in both externalizing, so kind of acting out, and more internalizing, so depression and anxiety type behaviors. The older the child is at the time of adoption, and typically meaning older than age 3, the more negative outcomes there are. There's more problems with aggression, hyperactivity, placement disruption, overall dissatisfaction within the family by the parent and by the child, and more impaired functioning. And multiple placements are associated with poor outcomes overall. It kind of becomes a chicken and an egg. So you have these kids who are removed more than likely because they've been at least neglected, if not abused as well. And that places them at risk for externalizing behavior problems, so they're more likely to act out, which that then places them at risk for being moved because families can't manage the behaviors, which then increases their risk for being moved again because they're more likely to have more behavior problems because they were just moved. It really becomes a vicious cycle. And what we also see in the kids who've been prenatally exposed is that because their behavior can kind of be more challenging in regards to their cognitive limitations, what they're able to do, what they're not able to do, and it tends to be really frustrating for parents. These are kids that don't respond well to typical methods of learning. They don't respond well to typical types of discipline. So a lot of times parents get frustrated very easily with these kids and don't understand what's going on because they've not been given the information, and that will contribute to more placement disruption. So the cycle just kind of continues. The worse the placement history is, the worse the behaviors get, but the placement changes and the placement disruptions are being driven by these behaviors, which are a result of their traumas and their multiple moves. So one study that really kind of drives home how important placement is in all of this, it was a study that was done. It's called the California Long Range Adoption Study. And it was a great study. It was longitudinal. It looked at kids post-adoption at 3 different time periods. So they looked at kids 2 years after adoption, 4 years after adoption, and 8 years after they were adopted. We looked at roughly 300 kids. Male-female split was even. You can see the racial distribution. And most of the kids were neglected. They had a higher rate of sexual abuse than what's, I think, a little typical. And then there was a 20% rate of physical abuse. Over 50% of the kids were prenatally exposed to drugs and alcohol, and depending on kind of everyone's state and where they're coming from, I think that's pretty typical for the kids that are involved in the child welfare system. The last study that I talked about, they had an average of 5 placements for the kids. This one, they had an average of 1.5 placements per child before they were adopted, but it went anywhere from 1 to 10 placements for the kids. So it was a pretty wide range. And I will say, personally, for what I see clinically, that's pretty typical. I think the worst I've seen is 15 placements. And I actually did say 15 placements in a child who was about 13. So this is, I think that range is pretty accurate. So what they did, they did these 3 waves. So the first wave of data collection was 2 years after they were adopted. And what they found was that 2 years after adoption, the kids who did the worst were the kids who had a history of neglect and the kids that were boys. The gender issue stayed the same throughout. That was always a risk factor. But the neglect, by the time they did that second data collection at 4 years after adoption, the neglect wasn't an issue anymore. It became the history of multiple placements and if the kids had a sexual abuse history. But that those were the kids who did the worst. But by the time 8 years went around and they were following these kids, what kind of permeated and what stuck was the multiple placements. That placed the kids at the highest risk for negative outcomes. And this could be due to a lot of different factors, but one thing that they found was that the worse that the kid did early on, kind of it grew each time. And that contributed probably to those early placement disruptions, the number of placements that the kids had. Interestingly, they didn't just look at what made the kids worse. They also were trying to figure out, okay, well, why did some kids do better? What made this not as severe in some kids? So what was mediating this? And so what they found was that 2 years after the adoption happened, the thing that resulted in better outcomes and kind of made those negative outcomes not as bad was if the parents rated themselves as ready to have the child. And what that meant was, did the parents have a realistic expectation of what it was going to be like to have this child in the home, or were they going in with some degree of being naive and that it was going to be perfect and wonderful and marvelous and they'd be able to fix the child? So the parents that were more ready and kind of had more realistic expectations of what it was going to be like to have the child in the home, what the adoption was going to be like, did better 2 years after the adoption. 4 years after the adoption, what they found was the same thing. The more that the parent rated themselves as ready for the child, the better off they did. And they also looked at kind of the parent-child interactions, and the more positive parent-child interactions, the better off the kids were. 8 years, the one thing that stuck was the parent readiness. And so again, by 8 years out, when the worst things, kind of the things that resulted in the worst outcome for all these multiple placements, the best thing, the thing that helped the most is that the parents viewed themselves as ready. And interestingly, what they found was out of all these different risk factors that these kids had, the abuse, the neglect, the multiple placements, the thing that made the biggest difference, and it was actually, it helped things more than any of those risk factors may increase the risk, was that parental readiness variable. And that's really kind of a key thing, and in my clinical experience, that's been a key thing. So often, you know, I see foster parents come in and adoptive parents come in who don't have a good understanding of what their child's needs are. And they don't even, a lot of times, have an understanding of, in general, what abuse and neglect is and what that means for the child and what that means for the long-term outcome. And that's what the study is really showing. If the parents have a good understanding of this, they tended to do better and their kids tend to do better. And there's a little bit of bias to this, because it very well could be that the parents who are rating themselves as not ready were always the ones that had the most challenging kids. And looking back, they always would say, "Eesh, we were never ready for this child. They, you know, he or she did whatever, and we've never been able to handle it." So there's definitely those parents who were included in this, but there were also enough of those parents in there that felt like they were realistically ready, knew what to expect, and if they didn't know what to expect, knew that that was okay not to expect it, and they were able to handle the kids better and do better over time. So keeping all of that in mind, I'll tell you guys a little bit about the clinic that we have downstate. It's funded through a grant through the Administration for Children and Families. In order for us to see the kids at the clinic, they have to have some type of history of prenatal or environmental substance exposure. So it's definitely a little bit of a skewed population. We first started seeing kids in 2008, and as of a week ago, we've seen probably about 450 kids just for evaluations and around 140 families for therapy. The data that I'm going to show you is based on a smaller subsample. It's based on up until, I think, through last fall, so it's about 200 and some kids that's included in here. It's just not the most updated numbers. So we've seen kids from birth to 21. The mean age that we saw was 8. The gender, ethnicity, all of that was definitely more boys that we saw than girls, but the ethnicity is similar to the population that's in southern Illinois, which is a more rural area, but it's also pretty diverse because we pull kids from also like the suburbs of St. Louis because of where we're located, down to some pretty rural areas that have no resources. So it's a pretty wide range that we see. The kids, most of the kids that we saw we're not, when I say DCFS involvement, we're not actively involved with DCFS. Most of them had already been adopted or were guardians. When we look, the kids that were with foster or biological, a significant percentage of the biological kids did have in-fact services going on at the time, in addition to the kids that were involved with DCFS, which is our child welfare system, through traditional foster care. So when we look, yep.
One attendee asked, was the parent readiness a global understanding of the needs of a foster care child, or was it specific to education to the needs of that specific child?
It wasn't, if I'm understanding the question right, it actually wasn't, read the question to me one more time.
I think when you were talking about readiness, they're wanting to know, was it based off the readiness of the needs of foster children or specific to the need of their child?
Specific to the need of their child, but it wasn't even, I mean, the interesting thing about the way that they did that was they just asked the parents broadly, did you feel like you were ready for this child? So it wasn't like they were measuring specific variables. It was really the parent's opinion of themselves, to put it kind of bluntly. Like, did the parent feel like they were just ready to take care of this child that came into their home? So it wasn't necessarily looking at specific variables, just that person's rating of themselves, really. So, and that was the other thing that was kind of interesting about that, was just, did the parents inherently kind of feel like they were able to care for the kid that came into their home, and were they ready for it? And if they did, not based off of knowledge surveys, not based off of anything else, that self-awareness, self-whatever, that confidence was enough to be a protective factor for these kids. But knowing what we know and knowing kind of what it takes to feel ready for these kids and how challenging they are, there's things that have to kind of come into play with that, and that we'll talk about in a minute when we talk about kind of treatment implications and policy implications. So going to our clinic just for a second, this is kind of the distribution of what substances kids were exposed to. Vast majority of the kids had some type of environmental exposure, meaning that the parents were actively using substances in the home. And then as far as prenatal exposures, most of the children were exposed to alcohol, followed by cocaine. When we look at this, the general line, so the is looking at CDC, or sorry, National Institute of Mental Health statistics, so national averages of disorders within kids, and we're comparing that to the DCFS kids seen at the clinic that I run. And our DCFS kids had much higher rates for everything except for anxiety. Their anxiety rates were slightly lower, which was interesting. But what was hard to pull with this was trauma, because the way that some of this was measured, the general rates didn't reflect trauma rates, so it's hard to kind of know where to put those kids. But overall, the kids that we were seeing have a much higher rate of mental health issues than what's seen. So what kind of becomes, and this goes back to that last study, when we look closer, I kind of pulled out the DCFS versus the non-DCFS kids. So the non-DCFS kids being the kids who are already adopted or the kids who are already in guardianship. And they actually were doing a lot worse at the time that we saw them compared to our DCFS kids. And there's a couple of reasons why this might be, and we're still in the process of kind of trying to sort this out and understand it. One reason could just be that developmental trajectory of trauma that I talked about, that these problems persist over time. They don't just get better at one intervention. The other thing that happens is the DCFS kids, although this clinic is an area that's really very underserved and has limited resources, the DCFS kids do have access to more services a lot of times than the kids who've already been adopted, because they have active case managers and they have lots of people that are involved in their case and are monitoring them and making sure that they are getting services. So, but by the time that they're adopted and go through, there's not nearly as many resources for the families, particularly as some of those problems reemerge as the kids get older. So the kind of one way that we've kind of understood this and have kind of tried to start working on this is understanding that these problems do persist and do continue even when they resolve at a younger age, then they start to become kind of more problematic again as the kids get older. So one thing that we've tried to do is work within the systems that we have to try to figure out, okay, so we know that these kids after adoption are at risk for more problems given their early history of multiple placements and trauma and all of these things that have happened in them. What can we do within our system of care in this one area of Illinois to try to make sure that they're getting the services that they need? And we've formed relationships with our post-adopt services. We've formed relationships with adoption preservation to try to make sure that we can get services in place for these kids. And then we just work directly with the families to try to get the kids the therapy and services that they need, kind of serving as the case managers that the DCFS kids have that are able to kind of help access services for them. But then our staff does that for these families that are already out of the DCFS system and don't have that resource anymore. So just as a brief thing, because we're going to wrap up fairly quickly, what percentage of the kids do you think the kids that you work with actually get the services that they need and are referred for? Should be closing soon. So the majority of people say yes, and 41% say no. Research actually has shown quite a different story, and clinically I can say from the kids that I see, I think more consistent with what I'm going to show you guys. Based on that national survey of child welfare that they did that was based on, that looked at 3,000 kids, what they've actually found was that of kids who had issues, which they were basing on the child behavior checklist, so kids that scored in the clinically significant range on that measure, which implies that they have some type of difficulty that was clinically significant and far above the average. Roughly 48% of kids had issues in that range. Of those kids, though, only 11% actually got the services or were getting any type of mental health services, whether that was meds, therapy, any type of mental health services. When you compare that to, the kids that needed the services and weren't getting them, it's pretty significant. And what this was showing is that the vast majority of the kids who need services actually weren't accessing them. And more specific, they kind of broke it down by ages. And interestingly, the kids that were kind of in the young end, so like the 3 to 5, 1 to 3 age, was a third of the population, so 33%, but they were only getting 7% of the kids, or 7% of the services. So even with early intervention, or even with like early childhood programs at the school, kids still weren't getting the services that they actually needed. And part of this is because there's more barriers to treatment a lot of times than there's not. And some of these factors, they're easily understood. Some of them, there's some things that I think we can do to work on. Foster parent and caseworker burnout is pretty high. Depending on your state, I can only again speak for Illinois, but the caseworkers in our state have extraordinarily high caseloads, and there's lots of kids with lots of needs, and it's hard to manage all of them. And same with foster parents who, particularly for the clinic that we see in Southern Illinois, there's a shortage of foster families. And what inevitably ends up happening is that a lot more kids get impact services down there. But the foster parents that they do have are often being asked to take more challenging kids, higher numbers of more challenging kids, and kids that they're just not prepared to deal with. And so there's higher rates of burnout. Foster parents aren't empowered to help the kids. In a system where in order to seek mental health services, the child welfare system has to consent to them or consent to anything beyond routine medical care. Foster parents a lot of times don't feel like they have the ability to make decisions about the kids. They don't know how to advocate for the kids. They don't know how to access services. We'll see families and we'll recommend that they go do whatever, X, Y, and Z. And the foster parents don't have any idea about how to to start that process rolling. And that's where it's great when they do have caseworkers that are able to help them, but a lot of times, because the caseworkers have such high caseloads, it takes longer than to get things in place. The frequent placement changes is a huge barrier to treatment. In an ideal situation, even if a child moves placements, you would keep the same service providers, whether it was for mental health or medical services or whatever. The reality is that doesn't happen. A lot of times kids move placements, and that means that their therapist has to change, that their doctor has to change. So the people that really should be providing that stability for the kids and the treatment that they need disrupts, and they have to start all over. And when you're dealing with a kid with a trauma history, every single time that you have to retell your story or go through what's happened to you, it's another trauma for the kids, and it's a different type of trauma, but it's still another trauma for the kids. There's a real limit to quality care, and that's because most of the kids are limited by Medicaid funding. Fewer and fewer doctors are accepting Medicaid, and fewer quality doctors are accepting Medicaid. So a lot of times you end up with younger doctors or overworked doctors and facilities that are treating the most complicated kids, or when it comes to mental health services, more and more people aren't taking, for outpatient services, aren't seeing kids because of the Medicaid issue, and so that pushes kids to a higher level of care. So rather than being able to get good outpatient care to help manage, whatever mental health issues the kids have going on, they end up being pushed to inpatient services, or they end up getting pushed to residential or group home services because that's the only way to get the kids' mental health needs met. There's not good continuity, can't say that word today, continuity of care, in part because of what I talked about with the placement disruption, and in part just because of difficulty with records not transferring. One caseworker takes over from another, and records aren't always there. Providers can't access each other's charts that easily, and there's not a lot of coordination between providers. If you have a child who's in multiple different services, trying to coordinate between all of them is really critical, but it doesn't happen a lot of times. Another barrier to treatment is lack of accountability. It a lot of times becomes, well, I thought this person was doing it, I thought that person was doing it. There's never, a lot of times, not one person who is truly accountable for the child and truly accountable for their treatment, and that is the one that's responsible for making sure that these things get done that can help them. And so that can be a barrier. The funding issue, which I won't belabor this point with just Medicaid, but depending on your state, the budget cuts to Medicaid, the amount of time that it takes to get paid, more and more people aren't accepting it. And there's also an issue that a lot of times kids don't qualify for therapy services or for mental health services because they're not quite sick enough yet. And because they're not severe enough, they don't get the services that they need. There's not routine screening. Even when there is even if your state is routinely screening every child who comes to the child welfare system for mental health issues, if you do it at point of entry, that's great. But as we kind of saw today, point of entry is only one point in time. The kids' issues change over time, so they don't always routinely screen the children at different points. And even if they are screened, and they're screened consistently and across time, no one a lot of times knows what to do with the results of the screening. So it becomes pretty difficult to translate screening into actual care. Foster parents and caseworkers aren't properly trained. I talked about that a little bit earlier with parents coming in and not knowing, but I've seen it with caseworkers too, where, an example of that, a 4-year-old who had a pretty bad history of neglect, was in a good foster placement for a while. The foster placement disrupted for various reasons, and the way that they moved the child was just to show up at the door, pull the kids in the home, and put them in a new home the next day. The child's behavior completely regressed. The toileting regressed. He was having crying episodes, sleep disturbances, and the caseworker thought that the child was possibly on the autistic spectrum and wanted to get him into pretty intense behavioral therapy. It took a lot of talking and educating the caseworker to understand that it was the child's reaction to this disruption, and what really in this child's mind was mommy for as long as he could remember. So there's not really great education a lot of times for caseworkers and for frontline staff. The type of maltreatment can actually be a barrier. It kind of sounds weird, but it's better to have a more visible type of maltreatment history. kids who tend to have a history of physical or sexual abuse are more likely to get treatment than kids who are neglected. And it's not because they necessarily need the treatment more or need the treatment less. It's just that systems tend to be set up that way. Most states have child advocacy centers that kids with histories of sexual abuse are able to go and get treatment. Same with physical abuse, but neglect is neglected. It's neglected by treatment providers, and it's neglected by it's been neglected by researchers over time. But it's kind of that passive versus active type of abuse. The more active abuses tend to get more services, and so the kids long-term might do a little bit better. Another thing that can be a barrier is just attitudes and beliefs about mental health treatment. You're placing kids into a home of a caretaker and you're asking them to take care of them, but not all foster parents and not all people in general believe in counseling or believe in therapy. So trying to work with someone about what their personal beliefs are and helping them understand that this is what the child needs and that, yes, this might have worked with raising for your child, but this is what this child's specific needs are is really important. And I know we're running short on time, so the one thing I want to talk about just briefly is just the treatment implications, and I'll leave the policy implications for you guys to read on your own. But what this kind of implies for treatment is, one, is continuing to reinforce the importance of trauma-informed treatment and trauma-informed care, which I think that's starting to become universal, and it's not just that we're doing trauma-focused CBT with kids, but the idea that we're recognizing that all of these different things are traumas, not just abuse and neglect, but also multiple placements, different education systems, different caregivers, that all of these things have to be recognized and be dealt with and be managed. And I think as a whole, the more that we're able to do that and the more that we're able to kind of have that be one of the backbones of us understanding the kids that we work with in their mental health issues, the better off we'll be. Treatment has to address kids with neglect, not just those active forms of maltreatment. So really trying to make sure that we talk about and get services for kids that are neglected and do more research on the neglected kids, because they definitely don't have as much research out there on outcomes and types of treatments that are as effective as what some of the other types of maltreatment do. Earlier we intervene, just like with most things, the better off they are. So, screening kids early on, once the kids, if they're screened and there's any implication that they need services, getting them services then rather than, well, let's wait it out or let's get a more thorough evaluation. It's the type of situation that if you screen a child and they're showing any kinds of mental health issues, starting therapy is the best thing that we can do at the time for the kids rather than waiting around for more assessments. And those things can still happen, but we still need to intervene as early as possible and try to get the help that the kids need. We have to address parental substance use, and not just in the parents in the reunification process, but also kind of keeping that in mind as another kind of backbone to treatment for these kids, is understanding the implications that might have for them as far as prenatal exposure, environmental exposure, all of those different factors. And foster parents have to be educated. Different systems, even within Illinois, depending who your foster care agency is, foster parents are provided with different levels of information about the child's background, about the child's needs, and foster parents can't be kept in the dark. There is definitely confidentiality that has to take place, and there's that piece that's very important to protect for the parents and for different people. But they need to have an understanding of what the child's been through and what that means to the child in order for them to have any ability to help the child and actually parent them and care for them. So that becomes really important. And then actual education about what trauma is, what that means, what mental health is, and what risk factors are for mental health problems and for their child in particular becomes really important. And then finally, there's such a big push for empirically supported treatments, which is great, and it's important that we're doing things that we know that work. But that being said, we can't sacrifice the importance of individualized care for just doing empirically based treatment. One thing over the last few years of working with this population, and particularly with the kids who've been prenatally substance exposed, that it's taught me is that empirically based treatments only go so far because they're typically designed and done on a very set population. It tends to be a quote normal population as far as cognitive impairments and not having all the complications that the kids that we actually work with have. So sometimes those empirically based treatments are great places to start, but when you're dealing with kids that have this multitude of problems and multitude of factors that are going on, you have to individualize care, and you have to be willing to think outside the box and seek out services, supportive services, so seeking out OT and speech and working with all of these different caregivers and treatment providers together in order to best serve the child. So I think because of time, we'll stop because I know we're over. And then the last few slides are just policy implications, which are a little bit more straightforward. And to see if there's any other questions, and I think that's it.
Thank you, Erin, for your presentation today. In lieu of what time it is, we would like to have all questions that have come in. We will attempt to address them over email and get back to them that way. And we thank everybody for all of the great questions that have come in and the dialogue throughout the day. Thank you for everyone for joining us, and please remember to complete your evaluation for today's webinar, and we look forward to having you for the rest of our series.